Morning, respected teachers and my dear colleagues. My case is a 53-year female housewife, resident of Una, Himachal Pradesh, admitted on 28th of March and died on 1st of April with 5 days of hospital stay. Patient was admitted with chief complaint was a generalized weakness and extreme fatigability since December 2021 and intermittent fever, shortness of breath on exertion since January 2022 and loose stool since 2 weeks. Patient was apparently all right till December 2021. Then she developed generalized weakness, extreme fatigability, intermittent high-grade fever with chills, progressive exertional dyspnea. For this complaint, patient was admitted at local hospital, Una. She was diagnosed with type 2 diabetes and found to have pancytopenia. Patient was managed conservatively and she received 4 units of PRBC transfusion. Patient was referred to PGI for further evaluation and management. Patient came to PGI on 30th January on presentation she had gross pallor, no lymphadenopathy, USG showing hepatosplenomegaly and there is pancytopenia on hemogram. Possibility of acute leukemia was kept and patient was discharged after bone marrow on 1st February with advice to follow up with report. Meanwhile, patient was admitted in Sector 16 hospital where she was managed conservatively and received 3 units of PRBC. Patient came for follow-up with report on 16th of February. Her bone marrow showed 80% of blast cells and markedly reduced erythropoietic and megakaryocytic lineage. Marrow was consistent with ALL. Flow cytometry of the marrow showed positive for B cell marker and negative for myeloid and T cell marker. Molecular genetics of the sample showed positive for BCR ABL transfusion. Diagnosis of Ph positive B cell ALL was made and patient was started on vincristine, tyrosine kinase inhibitor and steroid-based alternate protocol. Patient received 5 cycles of vincristine, last dose on 24th of March and she was started on dasatinib 70 mg and Visolon 90 mg and other medication like allopurinol, Septon-DS and acyclovir. These are the blood investigation of the report when she was on induction therapy. She had a hematological response and she had new onset of transaminitis. Patient this time presented with chief complaint of loose stool since 2 weeks, 6 to 7 episodes per day, small volume watery diarrhea associated with pain abdomen which was mild and poorly localized. No history of vomiting or jaundice. Patient, there is a documented history of bleeding PR in ASA file and history of prior symptoms worsening. Past history, recently diagnosed type 2 diabetes, family history not significant, and history of multiple transfusion was present. General physical examination, she had gross pallor and oral thrush was present and her blood pressure was slightly lower side. Systemic examination just showed left-sided crepes, rest of the systemic examination was grossly normal. This is the hemogram of the patient showing pancytopenia with severe anemia. She received 2 units of PRBC transfusion on 30th March. PBF showed leukoerythropoietic picture and their coagulogram was normal. Biochemistry of the patient showed hypoalbuminemia, hyponatremia, conjugated hyperbilirubinemia. Sepsis worker blood culture was sterile, fungal marker was negative and procalcitonin was raised. Blood gas analysis of the patient showed type respiratory alkalosis which is chronic and partially compensated. USG of the abdomen was normal and there is a hepatosplenomegaly which was resolved. HRCT chest was minimal bilateral pleural effusion. CTPA was done, there is no evidence of pulmonary thromboembolism. This 53-year female with type 2 diabetes and Ph positive ALL was on alternate protocol, was presented on 28th of March with a complaint 2 weeks of loose stools and worsening of prior symptoms. On examination, she had oral candidiasis and left-sided crepes was present. Dasatinib and Visolon was stopped and she was started on IV fluid, antibiotics, metronidazole and ciprofloxacin, clotrimazole, morphine and other supportive treatment. On 29th night, patient was shifted to female medical ward under Chammo. Patient developed on next day, patient developed hypotension, tachycardia, tachyapnea and fever spikes. HRCT done which showed bilateral pleural effusion, however there is no consolidation. Overnight culture report came out to be sterile. Patient was given IV fluid challenge and started on inotropic support and ciprofloxacin was stopped and started on magnesium. On 31st March, patient was maintaining MAP around 70 mmHg with single inotropic support, and she was persistent to have tachycardia, tachyapnea, and fever spikes. ECG showed sinus tachyarrhythmia. CTPA was done. There is no evidence of pulmonary thromboembolism. Patient was continuous same line of management. During terminal vision, patient was continuously having high grade of fever, tachycardia, tachyapnea, and drop in MAP. Blood gas analysis showed chronic respiratory alkalosis, and her lactate was raised. She was started on dual inotropic support, and antibiotic was hiked up to meropenem and vancomycin, and other supportive treatment was continued. After explaining the prognosis, patient attendant gave consent for DNR, and by evening, patient succumbed to her illness, and ECG was flat at 9:15 a.m. We have a 53-year female with type 2 diabetes, Ph positive ALL on alternate protocol, presented with above mentioned symptom. And on examination, she was febrile, pallid, tachycardia, tachyapnea, hypotensive, oral thrush was present, hypoxia, and left-sided crepes. ECG showed sinus tachycardia, respiratory alkalosis, pancytopenia, hyponatremia, hypoalbuminemia, conjugated hyperbilirubinemia, and raised procal. Blood culture was sterile, fungal marker was negative. We will discuss this topic under 3 heading: basic disease. Patient of hepatosplenomegaly in January, and pancytopenia and leukoarthropoietic with a possibility of a hematological malignancy. Bone marrow showing 80% of blast cells with reduced megakaryocytic and erythropoid lineage, possibly acute leukemia, and flow cytometry of the sample showed marker positivity for B cell and negative for myeloid and T cell, and molecular genetic of the sample was positive for BCR-ABL transfusion gene. It is the case of Ph positive B cell ALL. This is a table for Harrison, 21st edition. It says adult ALL incidence range from 0.7 to 1.8 per lakh population per year, and more than 70% of adult ALL or B cell origin. Ph positivity increases with age, and Ph positivity is associated with worse prognosis. This is a clinical trial and observation study of 349 patients in which adult ALL was studied. They found that adult ALL showed bimodal distribution in incidence, and majority of the patient had B cell lineage up to 81%. And they found that most common cytogenetic abnormality is Ph positive BCR-ABL, and prevalence of this BCR-ABL transfusion translocation increases with age, and they also found that prognosis worse in this patient. Complication: large bowel diarrhea. We have a known case of malignancy, neutropenia, fever, loose stool, and pain abdomen. Possibility is neutropenic enterocolitis leading to microbial infection. Likely bacterial, since there is raised procalcitonin, our culture was negative, or viral colitis could be the possibility, since it is a case of hematological malignancy, immunocompromised patient, type 2 diabetes, and there is transaminitis and cholestasis. However, CMV, PCR are not available. Possibility of fungal infection cannot be ruled out, and microbial infection cannot be ruled out in this patient. As there is a temporal correlation of diarrhea with dasatinib, I would like to consider this dasatinib could be the second possibility. And this is a meta-analysis of gastrointestinal adverse effect in patient with taking tyrosine kinase inhibitor of a CML patient, in which more than 10,000 patients was studied. They found that dasatinib is known causes the diarrhea in 28 to 30% of cases. And these are some article and case report about dasatinib induced. Malignant infiltration of bowel wall could be the other cause. Deranged LFT patient with conjugated hyperbilirubinemia, raised ALP. However, ultrasound showing no evidence of extrahepatic or intrahepatic biliary dilatation. R value 1.7. Possible it is an intrahepatic cholestasis. Possible this is a table for Schlesinger. Likely etiology could be a viral infection or bacterial infection, and as patient was on trimethoprim and sulfamethoxazole, which is known to cause a cholangitic injury, it could be the contributing factor, or allopurinol, which is known to cause granulomatous hepatitis and cholangitis, or it could be a malignant hepatic infiltration. Patient with uncontrolled uncontrolled blood sugar level is a case of type 2 diabetes.
Please try to wrap it up in next 1 or 2 minutes.
type 2 diabetes likely exacerbated by oral steroid. Terminal events, patient with hypotension and dual endotropic support with raised lactate. I would like to consider first possibility is septic shock because it's high grade of fever, raised procalcitonin and Q-SOVA score of 2. However, blood culture was sterile. In this case of known malignancy, immobilization and tachycardia with total total Wells score of 4, obstructive shock could be the. However, there is no evidence of DVT or D-dimer was not available and CTPA was a negative. It is less likely cause. And the patient was on high dose steroid and recently tapered, and she was not supplemented on hydrocortisone. Adrenal insufficiency could be the contributing factor. The unit final diagnosis is type 2 diabetes, uncontrolled blood sugar level, pH positive B cell ALL, post 5 cycle of VCR, dasatinib and steroid based alternate protocol. Oral candidiasis, gastroenteritis, likely neutropenic, enterocolitis, CMV colitis or drug induced. Sepsis with septic shock. Cause of death in this patient is refractory septic shock.
Good morning everyone. I am presenting pathology protocol of this case. 53-year-old female with these clinical details. Hemogram shows pancytopenia picture. Differential count was done. Polymorph 79, lymphocyte 17, monocyte 1, eosinophil 1, blast 1, myelocyte 1. Blast here shown in peripheral blood. Peripheral blood picture shows normocytic normochromic red blood cells with macrocytes, few obelocytes and elliptocytes. Platelets were markedly reduced. Many neutrophils of prominent granules. As bone marrow aspirate was aparticulate and hemodiluted, so imprint spear was taken for differential count. Non-erythroid to erythroid ratio 99:1, erythropoiesis markedly reduced. Differential count was done, blast 80%, promyelocyte 1, myelocyte 3, polymorph 5, lymphocyte 9, monocyte 1, erythroid precursor 1. Blasts are 2 to 2.5 times the size of mature lymphocytes, having high NC ratio, around 2 irregular nuclear contour, 0 to opened up chromatin, 0 to 2 conspicuous nucleoli, scant amount of basophilic A granular cytoplasm, no OR rods are seen. Bone marrow biopsy was variably cellular, normocellular to mildly hypercellular area. There is interstitial increase the immature cell, stromal edema and mild fibrosis was also noted. Granulocytic and erythroid lineages were reduced. Megakaryocyte lineages were adequate. Flow cytometry analysis was also done. This saw approximately 3% of all viable cells show CD45 dim low side scatter events and also positive for CD10, CD19, CD20, cytoplasmic CD79A, cytoplasmic CD22 and CD81 and negative for T cell and myeloid cells. For further confirmation, ISC was performed. The immature cells predominantly CD20 positive and negative for CD3. A few residual MPO positive myeloid precursors are also seen. Molecular test was done that was positive for translocation 9:22 BCR-ABL1 major fusion gene. A diagnosis of acute lymphoblastic leukemia, B cell lineages BCR-ABL1 positive was made as an ante-mortem diagnosis. Now I am presenting this post-mortem finding. Partial autopsy was performed. Peritoneal cavity yielded 1600 ml of straw color fluid. Pleural cavities and pericardial cavity was within normal limit. Bone marrow biopsy was performed during autopsy that was markedly hypocellular for this individual. Further higher magnification we can see erythroid precursor and preserved occasional megakaryocyte, occasional blast cell, but blast cell was markedly reduced as compared to ante-mortem biopsy. Further higher magnification we can see pigment-laden macrophages and hemophagocytosis. Organ complex comprises of slice of liver, C-loop of duodenum, gallbladder, C-loop of duodenum, pancreas, and slice of spleen. Looking at weight, both liver and spleen was overweight. Closer look of portal vein did not show any thrombosis. Slice of liver was quite enlarged, capsular surface unremarkable, did not show any nodularity, and the cut surface so yellowish and greasy in consistency. But low power, we can see here diffuse macrovascular steatosis. And also here we can see periportal and perivenular macrovascular steatosis. On further higher magnification, we can see numerous Mallory Denk bodies inside balloon hepatocytes. This better highlighted on this mesenteric stent. Also, we can see fibrosis with connecting central vein or portal tract, which is better highlighted on reticulin stent. Also, on mesenteric stent, we can see perivenular and pericellular fibrosis. Pulse stent was also performed, which he saw 3/4 positive hemosiderin granules inside Kupffer cells. This is essentially a case of steatohepatitis type of liver injury, which could be NAS-related or drug-induced. Apart from this, there is also hemosiderosis, which probably a case of transfusion-related. Spleen weight 345 gram. Microscopic examination show intact red pulp and white pulp. And CD20, CD3 shows a normal lymphoid pattern. A further higher magnification shows, did not show any blast infiltration in splenic parenchyma. And further, there is evidence of extramedullary hematopoiesis and
hemophagocytic. Interrupt. Dr. Pawan, please briefly mention only the positive finding. Okay, sir.
Both grossly and microscopically, pancreas was unremarkable. Organ complex comprises of trachea, bilateral bronchi, and bilateral lung. Bilateral lung weight 870 gram, and which is subcrepitant to field. Pleural surface shows the vocational patchy dullness and fibrinous tracts. Cut surface did not show any significant pathology. And microscopic examination of bronchopneumonia along with air tapping. And further higher magnification, we can see numerous neutrophil and macrophages inside alveolar spaces. And there is focal thickening of this interstitium also noted. Certain cells show cytomegaly, includes pneumocyte and endothelial cells and macrophages as well as stromal cells. Here we can say prominence of pneumocytes. Certain cells show cytomegaly and nucleomegaly both. We can see here intranuclear inclusion, perinuclear halo, and peripheral chromatization. Also, we can see here basophilic cytoplasmic inclusion, which confirms the morphology of cytomegalovirus. Cytomegalovirus was diffuse, which was seen in every section which was taken from the lung. Here we can see local, this is focal necrotizing inflammation, also entangled fungal hyphae infiltrating into the lung parenchyma. Entangled fungal hyphae that showed septate, slender, and acute angle branching, which confirms the morphology of aspergillus. In addition, pulmonary edema was noted. There is large rectal ulcer measuring 5 into 4 centimeter, which was noted here with saggy ulcer surface. Multiple section was taken from this area, which is deep ulcer covered by fibrinous exudate. This ulcer bed shows colonization of candidal pseudohyphae, which is further highlighted on this PS stent. On searching, we also documented that similar kind of CMB inclusion also noted in this rectal tissue. On mesenteric, this is better highlighted on this mesenteric. Right ovary shows cystic lesion, which we can see here, prominent hair sac, prominent teeth coming out, and microscopic section from the same, which shows consistent with mature cystic teratoma. Organ complex comprises of bilateral kidney, bilateral ureter, urinary bladder, part of abdominal aorta, and part of inferior vena cava. Bilateral kidney bed 420 gram, capsular surface unremarkable. And cut surface shows distinct corticomedullary junction, did not show any cortical scar or any papillary necrosis. And this PS highlight normal morphology of glomerulus and tubules. and his PSLR, these glomerulus did not show any diabetic nephropathy changes. And further, we can see benign nephrosclerosis in the form of reduplication of internal elastic lamina of the arcuate artery, and also mild mediointimal thickening. Heart weight 320 gram. Heart was opened by modified inflow and outflow technique. All the chambers and valves are unremarkable. Coronary artery also dissected, did not show any coronary artery disease. Microscopic examination did not show any significant pathology. And grossly and microscopically, stomach, esophagus, large intestine and small intestine did not show any significant pathology. A microscopic examination for adrenal, skin, uterus, thyroid was unremarkable. No CMV occlusion or no blast infiltration was noted in any of these organs. Known case of Philadelphia positive acute lymphoblastic leukemia on treatment, hypocellular marrow, occasional residual blast in bone marrow and no extramedullary infiltrate. Final autopsy diagnosis cytomegalovirus pneumonia with pulmonary edema, invasive pulmonary aspergillosis, cytomegalovirus proctitis with superadded candidal colonization. Steatohepatitis could be non-alcoholic or drug-induced, and mature cystic teratoma of right ovary. Thank you.
Thank you, Dr. Pawan. Please join me here. Now I'd like to invite senior resident from pathology for his comments.
Good morning, everyone. So basically, there are three aspects in this case. So there is the primary disease, which is the lymphoblastic leukemia, and on postmortem examination, in any of the sections, we did not find any blast infiltration. Even in the bone marrow sections, the blast count was quite reduced. So that is one thing. Second thing is the changes in the liver. There is extensive steatohepatic changes, lot of malaritic bodies, those things are there. Now we don't know exactly what could be the cause. More than NASH related, that could be secondary to his heart therapy related changes, possibly we can consider. The third thing which possibly has considered the death of this patient is the superadded infections. The CMV pneumonia, it is quite extensive, involving all the lobes of the lung. And the second infection that is there in the lung is the aspergillosis, invasive aspergillosis. Third thing is the infection in the rectum. Rest of the colon, we did not find any significant pathology, but the rectum was involved and it shows CMV infection plus one rectal candidiasis. Occasional hemophagocytosis we could identify in the sections from the liver, not from the liver, from the spleen and in the bone marrow, but we don't know whether this has to be considered as significant or not. So these are the things.
Thank you, sir, for your valuable comments. Now the case is open for discussion. Jen, sir.
Issue is about CMV disease versus infection. Now, just want to know from the pathologist that, mere presence of CMV will not make disease. It will make presence of infection, that's all. So what would be the response of CMV pneumonia? You are saying that there's extensive CMV pneumonia. Well, presence of CMV, as I'm again repeating, there has to be some form of response, despite the fact that the person is neutropenic. Presence of organism, does it really mean that's the killer? Or naturally anybody would say that CMV predisposes, on the top of it, person is neutropenic, so predisposition. And then second point, the clinical diagnosis was that of neutropenic enterocolitis. I believe that the diarrhea must be extremely, extremely serious, rather than one or two stools. So just a proctitis, so is clinical pathological little bit discorrelation, or you believe that diarrhea is just, we keep on, how do you, or is it possible that the early changes of neutropenic enterocolitis are missed on histopathology? Because it's possible that many of these things are functional rather than true pathological.
So, first of all, sir, CMV in lung we do not see so often. It is usually dormant in the ganglionic cells. First of all, there was diffuse CMV inclusions that we saw, and secondly, there was a reaction associated with it in both rectum as well as in lung. So this reaction we cannot really ignore, and that's why we call it a CMV infection and not just CMV inclusion. The second point is in rectum also, if we can go back and see, there were multiple neutrophils as well as nuclear debris, which is not the usual case of neutropenic enterocolitis. And neutropenic enterocolitis usually involves the cecum and terminal ileum, this kind of region, which was in gross morphology quite all right. But as you have mentioned rightly, that this could be functional or drug-induced at the beginning, and then we have just seen CMV proctitis. Thank you, sir.
Pankaj.
CMV activation happens in ALL because these patients are immunosuppressed and steroids, heavy dose steroids for 4 to 6 weeks they receive. But definitely the disease causing sometimes, if there is symptoms and other signs, only then you can say. My question is about there was a peritoneal effusion, 1600 ml in this patient. What was the reason for that?
The answer is I really don't know. It was the prosector's note, so we have mentioned it, but I really don't know whether to believe it wholeheartedly or not, and what is the reason for that. We could not find any peritoneal exudate or anything of that sort. Thank you.
Jan, sir, please.
Well, if somebody mentions 1600 ml, I would believe that. I will not say that I would always believe the resident, who's done it. The point I made earlier, like many times the exudation does occur. There is a capillary leak. That's why I was saying that, the gut becomes leaky. And it's not only with the one bacterial infection, it can happen with possibly viral infection. That's the point so you said that many times occult puffs and all those things. It's very difficult to, unless somebody looks, or maybe I don't know how do you find puff in pathology, whether you instill water and then look for leakage, or you instill air and then look for leakage. I just want to learn, how do you look for leakage? Unless it's grossly seen is seen, but doesn't mean I'm taking analogy from car tires.
During autopsy, we do not insufflate water or anything at all for the simple reason that cause loss of the architecture of the gut and to preserve it. So we do not do that if there is no prior intimation. Otherwise, we just clean the gut and we keep it fixed. So there is no way to say that there is an occult thing.
So, do we get any clues from the mesentery covering it up? So, since we are running out of time, I'd like to invite Dr. Savneet to present the second case.
Good morning, everyone. Now moving to the next case. I am presenting case of 40-year-old gentleman, resident of Ludhiana, who presented in the EM OPD on 2nd September 2021, and the duration of stay was of 8 hours. He presented to us with the chief complaint of shortness of the breath since past 1 day, difficulty in swallowing liquid since past 1 day, and altered mental sensorium since the past 1 day. Now coming to history of present illness, the patient has acute onset episodic shortness of breath, which was aggravated when the patient was trying to drink water. The patient attendants also complained that the patient has sense of ghabrahat and fear on seeing the water. However, there was no history of any chest pain, palpitations, no history of any pedal edema, no history of orthopnea or PND. There was also associated with altered sensorium in the form that patient was restless, agitated, was moving here and there, and required 2 persons to restrain him. It was also associated with mild, dull aching epigastric pain, and which was also accompanied by a single episode of vomiting. Now coming to the past history, there was a history of streak dog bite over the left, over his right lower limb near the ankle region 5 months back. It was unprovoked bite, grade 3 injury, and the patient received full dose of rabies vaccine as well as rabies immunoglobulin. The first dose of vaccine and rabies immunoglobulin was within the 4 hours of the onset of the bite. Rest is, past history is non-significant. Family history and personal history is also non-significant. Now coming to the general physical examination, the patient on arrival to the EM OPD was agitated. He was tachypneic and having tachycardia and was maintaining a saturation of 95% on the room air. However, his general physical examination was unremarkable. Now coming to the systemic examination, his pupils were bilaterally reacted to the light and were normal in size, and neck rigidity was present. Other tone was normal, he was moving all his 4 limbs, and reflexes were 2+, all reflexes were 2+, and plantars was bilateral flexors. Rest system examination was uneventful. Now coming to the set of investigation which we have only had the presence of leukocytosis, which was neutrophilic predominant. Now coming to the course and management of the patient, 44-year-old gentleman with a complaint with a history of dog bite 5 months prior, presented to the EM OPD with a complaint of hydrophobia and altered mental sensorium. On arrival, he was tachypneic and tachycardia. He was intubated on the same day in the view of inspiratory spasms. Next day at around 1 a.m., the patient had sudden onset fall in the BP and was started on the inotropic sport. At around 4:10 a.m., the patient went into asystole and CPR was initiated as per the ACLS protocols. However, despite the CPR, the patient succumbed to his illness. Now coming to the discussion part, we will discuss the patient in the following headings. First is the primary diagnosis. Primary diagnosis in this case will be rabies and encephalitis. The points favoring is the presence of the dog bite and the onset of the symptoms occurring after 5 months of the dog bite. Also, there was preceded by prodrome of vomiting and the pain abdomen, and there was a typical history of hydrophobia. However, the patient was completely immunized, but there are few case reports which highlight the vaccination failure. So we keep this diagnosis as a first probability. Other differential which we can keep in this case can be meningoencephalitis. The point favoring is the presence of altered sensorium, altered neck rigidity. However, there was no fever and there was no CNS imaging available. Other remote possibility can be kept for septic NCAF in the presence of elevated TLC. However, there was not presence of any fever and no identified source of sepsis. Now coming to the clinical stages of the rabies, the stages can be divided into 4 phases. The first stage is that of the incubation phase, which typically is 20 to 90 days according to most of the studies. However, this can be varied as will be shown later. The second phase is that of the prodrome state, which lasts for 2 to 10 days. Here the patient presents with non-specific signs like abdominal pain, nausea, paresthesias around the wound. And then comes the acute neurological phase, which is broadly 2 types, neurological and paralytic type. In the neurological type, the patient is basically agitated with the symptoms of hydrophobia, and in the paralytic phase the patient presents with flaccid paralysis of the limbs which mimics the GBS, and last phase is that of coma and the death. This is the data of 30 years from Philippines, which show the variable incubation period of the rabies. Here the average incubation period of the rabies in the study was of 91 to 365 days. However, they have reported a incubation period of minimum of 7 days and maximum of that of 27 years. Now coming to the diagnosis of the rabies, antemortem diagnosis of the rabies is mainly made by the RT-PCR, which targets the viral RNA. It can be run on CSF, saliva, and skin biopsy. However, the skin biopsy has shown to be maximum sensitivity and specificity. And postmortem diagnosis is basically made with RT-PCR done on the neural tissue. Now coming to our main interest, that is causes of the post-exposure prophylaxis failure. The major cause of the post-exposure prophylaxis failures is that of improper wound care. Various studies have shown that adequate wound care in the form of cleaning of the wound with soap and water reduces the risk of rabies by 30%. Other cause can be the faulty injection technique of the rabies immunoglobulin vaccine. Ideally, the rabies immunoglobulin should be completely injected into the wound after the cleaning, and very minimal amount is inserted intramuscularly. However, there have been reports that shown that the physician usually insert the intramuscularly rather than the wound. Other causes can be inadequate dose calculation of the rabies immunoglobulin. Also, there can be inappropriate storage of the vaccine because it is a heat labile vaccine, and on higher temperatures, its potency reduces. Other cause can be an exceptionally large viral load, or patient has an underlying immunocompromised trait. Now this is a case report highlighting the importance of the local wound care as well as that of the rabies immunoglobulin. In this case, same dog has bitten two persons in the same area. One young boy which has received adequate wound care and rabies immunoglobulin has survived. However, the older one which did not receive any wound care or rabies immunoglobulin come to this illness. Besides the most causes of the vaccine failure occurs because we deviate from the WHO protocol of the PP management. However, this 30-year data which also demonstrates that there can be cases of true vaccination failure. However, they are very, very extremely rare. Now coming to the pre-terminal events, our patient had developed shock. The possible causes in this can be the autonomic disturbance. The points favoring it as sudden onset. It was associated with tachycardia. However, there was no presence of any hypersalivation, lacrimation, or dilatation of the pupil. Other possibility can be that of cardiogenic shock because sudden onset arrhythmias are also known finding in the rabies. However, no ECG or echo was done, and also cardiac biomarkers were not available. A remote possibility of shock can be kept of sepsis because based on the elevated TLC. However, no focus of sepsis was identified. So coming to a terminal event, the patient has sudden cardiac, most likely due to the cardiac arrhythmia or myocarditis. Another possibility can be due to aspiration pneumonia. So our final diagnosis is rabies, encephalitic form, cause of death cardiac arrhythmia, shock likely due to cardiogenic.